Good morning, friends. Today, our guest speakers are Dr. Joydeep Chakrabarti from Kolkata and Dr. Neeraj Siddharthan from Kochi. The first lecture will be by Dr. Joydeep. He'll be speaking to us on myths and beliefs in the practice of BMT and CAR-T cell therapy. As usual, these webinars are brought to you by Mumbai Hematology Group. Today's webinar is supported by Pfizer, Unipec, Natco, Lucien, and Nirvin. These are managed by Perfect Square. I thank Mr. Prasad Devolikar and the team from Pfizer, Mr. Yash Kalpesh and team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest, Dr. Jagdish Chandra from Delhi, our guest speakers, Dr. Jaideep Chakrabarti from Calcutta and Dr. Neeraj Siddharthan from Kochi. All our discussants were themselves eminent hematologists or hemato-oncologists, and you participants for sparing your Sunday morning, afternoon, or evening. Next weekend on Saturday, 27th of December from 7 p.m. IST or Ohio time 8:30 a.m. onwards. We have Dr. Cami Maddock from Ohio speaking to us on diffuse large B-cell lymphoma, changing treatment during 2025 and 26. And the very next day, Sunday, 28th of December from 11:30 a.m. onwards, IST, we have immunotherapy of myeloma, a game changer from Dr. Satish Kumar from Bangalore. Our discussants, their names have been put up over here alphabetically, and they are from various parts of India as well as from neighboring countries. Our first speaker, as mentioned, is Dr. Joydeep Chakrabarti from Kolkata. He is Director and HOD, Hematology and Bone Marrow Transplant, HCG Groups of Hospitals, Kolkata. He is also Honorary Visiting Lecturer at Ramakrishna Mission Seva Pratishthan, Sishu Mangal Hospital, Vivekananda Institute of Medical Sciences, Kolkata. And as stated earlier, he will be speaking on myths and beliefs in the practice of BMT and CAR-T cell therapy. Before he does that, it's my privilege to introduce our chief guest for the day, and that is none other than Dr. Jagdish Chandra from New Delhi. Dr. Jagdish Chandra is former director, professor, and head of pediatrics, LHMC, and associate KSCH, New Delhi. The chairperson, Pediatric and Adolescent Nutrition Society 2526, director, LHMC from March 2016 to October 2017, and the chairperson for the Hodgkin Lymphoma Study Group in PHOG from 2014 to 2017. The chairperson, Hemoglobinopathy and Other Red Cell Disease Group of Indian Pediatric Hemato-Oncology Group 2017 to 2020. Member of the expert group of MOHWF for the Guidelines and Prevention and Management of Hemoglobinopathies. It's published over 240 articles and chapters in the international and national journals as well as the books. My pleasure to invite him to inaugurate our today's webinar and also give words of wisdom.
Good morning. At the outset, I extend my very sincere thanks to Professor Agrawal for making me part of this webinar today. The Mumbai Hematology Group always brings out very exciting topics, and so are these topics today. In fact, the specialty of hematology as it is unfolding over the years, though it is becoming very vast, but at the same time becoming more and more fascinating. This is happening on account of the developments in the diagnostics as well as in therapeutics. On the laboratory side, there are several developments, including the availability of genetic tests, particularly the NGS and other genetic tests, which are now widely available, and that has made the precise diagnosis of disorders which earlier remained uncomfort. This is especially true of childhood onset genetic and hereditary conditions, be it RVC enzymopathies, membranopathies, congenital cytopenias, or primary defects of immunity. Better understanding of the pathogenesis and pathophysiology has led to new ways of treating diseases. Hemophilia A does not always require replenishing the missing factor VIII. one can balance the missing or decreased proagulant activity by reducing the anticoagulant activity. That is, the compound fitusiran just does that. We have stem cell therapy available for several disorders for almost 4 to 5 decades. But now gene therapy has come in a big way, through which editing or correcting the defective genes for conditions such as thalassemia and hemophilia has become possible. Other developments in therapeutics have led to availability of agents targeting specific molecules or managing complex disorders, and it is possible to maneuver your own cells for cancer treatment. So the talks today are on CAR T cell therapy, in which there is editing or maneuvering of the cells for cancer treatment, and the other talk is on inotuzumab, which is a CD20 directed antibody drug conjugate for leukemia treatment. So we are in for a very exciting session today, and I think I would stop here and would like to thank Professor M.B. Agarwal once again. Thank you, sir. Thank you.
Thank you, Professor Jagdish Chandra, for those kind words and sparing your time to inaugurate our webinar. It has been always extremely kind of you to be with us for our academic activities. And now let's get on with the first lecture. And I invite our speaker, Dr. Joydeep. Please go ahead.
Just share my presentation.
Sure.
Okay. So we all ready? Go ahead.
Yes, please.
So thank you, Mumbai Hematology Group, and especially thank you, Dr. M.B. Agarwal. It's always a pleasure to attend the meetings which are organized by the Mumbai Hematology Group. Thank you so much. So with this presentation, what we aim to do is to question. So we take quite a few things for granted, and the aim of this presentation is basically to question some of those aspects of our practice. It is not critical of anybody or anyone, and it is just going to be a little bit thought-provoking, if I can put it that way. I definitely have no financial disclosures on this, and I must say that, this idea of questioning this whole concept that you shouldn't take whatever we say for granted. For example, let's say furosemide for heart failure. What is the evidence? The evidence is when we give it to patients, we see it, but is there any written evidence? So why not question all the facts? And this idea was at its peak in Professor Robert Gale. And I have seen him, questioning all the things that we do in day-to-day practice. So it came from him, and in fact, he himself has got a very good presentation on this. So once we start, the first thing to question is whether guidelines are something which is useful or not. It is a very good idea, especially when we are training. And when we are training, guidelines becomes one of our saviors, really. The BCSH guidelines when we trained in UK, obviously some of the guidelines coming in India, IS-BMT is coming up with guidelines. But let's talk about a few guidelines which are sponsored by some of the business companies, the pharmaceutical companies. I have myself been associated with the guideline for prevention of cancer thrombosis, which was sponsored by one medical company, who incidentally is a sponsor in our meeting today also. Similarly, there are another one which I was associated with was when they were trying to bring L-Trombopag into second line. And I feel that, those kind of guidelines are something which perhaps look into something else more than science. And maybe, we really need to question each and every clinical practice guidelines as we go along. But to question that, one has to have that knowledge and experience also. And maybe, you know, I'm 50 years old now, maybe at this age, I am developing a right to question some of those guidelines. You know, at a point of time, it was said that smoke a cigarette and your throat feels fresh, but then again, it changes. So dynamic is the word which I should say about clinical practice guidelines, and they change from time to time again. So given what we have got, the evidence that we have got, I think, you know, you really need to question each and every recommendation of those guidelines with that. And we will go on to have some examples. And the first example is about this drug called venetoclax. We all know that venetoclax is mainly it came through the mitochondria. The mitochondria was a cell which was taken up by the eukaryotic cell and then became a organelle in the eukaryotic cell. And along with that, it brought a lot of enzymes, the capsaicin enzymes and all that, including the BCL2. And if we inhibit BCL2, we can increase apoptosis and kill a lot of cancer cells in a variety of malignancies. Now, one of the very important things that we learned is that if we give sorafenib, which is a FLT3 inhibitor, in patients with FLT3 mutated AML, it definitely helps. But if we can give sorafenib along with venetoclax, we not only block the BCL2 pathway, but we also block the MCL1 pathway, and thereby what happens is we get more apoptosis. So really, is sorafenib only given to patients with FLT3 mutated AML? Can we not give it to patients with non-FLT3 mutated AML? So that is a question that we asked. And there are reports where where people have tried that in non-FLT3 mutated AML, and the results have not been very convincing, but some of them have been. And what we have done, this is our data really, so we use sorafenib in all the AMLs post-transplant now, along with venetoclax and azacitidine. We give them a maintenance for 2 years. And nowadays, if you can have some CD45RA depleted cells or memory cell DLI, you can also add that. So that helps in the maintenance post-allogeneic transplant in acute myeloid leukemia. Now, this one was a very interesting case. In fact, this is Tushar. Tushar, in fact, came from Mumbai to us. He's back there at Mumbai. He had a mixed phenotypic leukemia. And when we got him, he had a TB and a myeloid clone. So we did a transplant on him with CD19 and TCR alpha beta depleted transplant along with post-transplant MDLI, and he goes on to ponatinib. So this slide tells us quite a few things. That yes, it answers the question about maintenance in allogeneic transplant for AML, post-allogeneic transplant for AML. And definitely sorafenib is one of the drugs which can be tried, even though these patients are FLT3 negative. The response is good. So that was one of the things. The next thing we come is the stem cells, and we will just quickly go through. This is the traditional kind of a stem cell hierarchy model. And what we find are the questions that we need to ask, that can we accurately identify human stem cells, and are they all CD34 positive? And the answer is really no, because we see that there are many cells which has stem cell-like properties which are CD34 negative. CD34 is one marker which helps us to identify this group of cells, which we will call hematopoietic stem cells. Now, in mice, we see that, some of the stem cells, when they come out, the naive stem cells are CD34 negative, and they only express CD34 after they start dividing. Is this the same in humans? We still don't have the right answer for that. And, there are certain CD34 positive cells in the marrow, but they're also not stem cells. So really, CD34 cells is not a synonymous to hematopoietic stem cells. And as said, that there are varying type of stem cell capacity of these cells, of different type of cells, and they don't have to be CD34 positive. But then what cells are responsible for the post-transplant recovery of bone marrow function? And, it is different types of cells. And we cannot ignore the contribution of the donor cells here also. So it is something which I think we still don't understand. And just labeling them as CD34 cells is again a myth more than anything else. And we know that there are different types of stem cells. Not only one type, different types of stem cells. Some stem cells remain dormant, some stem cells die early, and some stem cells go on dividing and giving rise to long-term recovery. So there will be a short-term recovery, there can be a long-term recovery, and there can be no recovery in graft failure also. One of the prime examples is this kind of transplant called haplocord transplant. Now, what we do is that we supplement a cord transplant with some haploidentical cells. And what we see in the long run is that the cord takes over gradually, whereas the haplo goes down in the majority of cases. Now, we have done one of those things here, and this is called Save the Sibling. So let's say a couple is born with thalassemia or any other rare genetic disorder. And what happens is that we want to cure that rare genetic disorder or thalassemia, which is not really very rare. Now, what happens is we get the couple to go to an IVF center. This is a doctor who presides on that. And he creates a baby with pre-implantation genetic diagnosis, making sure that the baby is a full HLA match and thalassemia free. And then, this guy's from another organization called Cord Life comes to us, and they store the cord blood and they manipulate the cord blood and they give it back to us. And what we do is that we do a transplantation with that cord and also supplement it with haploidentical cells from the parent. So that is called a haplocord transplant, and that is this under the Save the Sibling program. The other interesting part of it is that because Cord Life is storing the cells, they also pay the patient a lot of money to get the transplant done under their insurance. So a bit of socioeconomics more than or transplant economics. And haplocord transplants have been performed elsewhere also, and they get a very good overall survival and thalassemia-free survival. Now, our patient is also doing very well. It's almost 3-4 months that we have done it. I think we did it in September was the time that he had the transplant. So he's doing quite well so far. And as I said, your cord blood gradually takes over and the peripheral blood goes down. That's what we are seeing. The cord blood is now around 4%, whereas the peripheral blood chimerism is around 96%. It was 100% to start off with. So let's see how we go on that. So this tells us that, there are different types of stem cells and different dynamics and kinetics of those cells, which we need to keep in mind. Again, it's the same thing. So the number one belief is that we cannot accurately and precisely identify human stem cells. And we don't know which cells actually are responsible for post-transplant recovery. We guess it is the CD34 cell, and that is a very good guess, but understand that it is only a guess. And we think that residual recipient hematopoietic cells will contribute to a large extent to post-transplant marrow recovery. Now, we are all humans and we are subject to errors, delusions, beliefs, false beliefs. And when we believe that in a cult, or when we believe that in a group, we are called a cult. So, there are different cults. When I came back to India, there was a CMC Vellore cult. And now we have got quite a bit of a cult which is coming out from the north of India. And when we were trained in the UK, we came back, we were considered outsiders. So maybe we have also formed a cult. So it's very funny how that goes. But if we talk about cult, then I would then draw your attention to this volume 3 of this extraordinary treatise that was brought out in 1841, which is on philosophical delusions. So it is worth a read. And one of the things was that a very nice anecdote is about King George. And you know, King George was considered to be mad, and especially when he had employed a group of alchemists who were trying to change all metals into gold, and they were using arsenic. And whenever King George used to visit this alchemic chamber, he used to get this bout of madness with blue urine. So was it really porphyria, or was it just mad? So, you know, again, that was one of the treaties. But they're saying that, you know, we do have people who believe in certain things, institutes, thought leaders, uh, physician leaders believing in certain things, and we being trained under them, we go on believing those things until and unless someone comes and questions us. So it's, and those, one of those beliefs is this belief of granulocyte transfusion in allogeneic stem cell transplant. Does it have a role? Some people say yes. So that is the yes cult, and there will be the no cult. We use it a little bit differently. We tend not to use it for stem cell recovery. We use it in the desensitization protocol. And, you know, these are some of the patients who have had desensitization with a granulocyte, I would say a buffy coat on day -1. That is what we give them. Basically, it has got lots of antigens. The idea is that you absorb all the antibody through that. So on day -1, we give them as a protocol, or as an ingredient of the protocol for desensitization. Just excuse me. So the other thought belief is that there is a myeloablative dose of radiation. Now, one of those, there's very interesting anecdotes which has been written here. Again, you know, Robert Peter Gale was one of the authors there, was about this gentleman who had accident in Belarus. He was a cleaner, as far as I remember, and he got almost 18 grays of radiation. He didn't know that the cobalt machine was on. So he went on to clean the machine, and he got almost 18 grays of radiation. So from Belarus, he was shipped to Moscow, where he was kept in a completely isolated chamber. But one of the things, and you look, that the granulocytes, when they went down, they came up with only interleukin-3 and GM-CSF, and the platelets never fell down. So with this, the patient survived till almost, you know, day 120 or 110. So this tells us that you really, you know, where we were not able to ablate the marrow even with that 18 gray of radiation, the cells were still coming out. So there may be no actual dose of myeloablation with radiation here. So that is another belief which we really need to think hard about. T-cell depletion or post-transplant cyclophosphamide, ATG, yes or no? You know, previously when we used to go before this haplo thing, post-transplant cyclo came along, there were always two groups fighting with each other, whether you give, whether you use T-cell depletion or you don't, whether you use Campath and then it became to ATG, or whether you don't. So any transplant meetings we used to go, there was always this kind of a debate which was going on. The Europeans normally, you know, advocating that, yes, we do need to give T-cell depletion with ATG. The Italians, you know, were the pioneers of ATG as such, whereas the Americans, they didn't want to believe in T-cell depletion at a point of time. But what then happened is there was a combination of using ATG and PTCY when the haploidentical transplant came along. The Beijing protocol came along. We have started using ATG along with PTCY. So, you know, that, as I said, that beliefs can be dynamic, and more thought evolution, science evolution will always change the belief in one way or the other. MRD before transplants. Now, you know, if you know that I am myself, I'm a very big proponent of MRD before transplant. I really want patients to be MRD negative before transplants, because we find that the results are very good if they are MRD negative in AML and definitely in ALL. But especially in AML, how far would you go to make a patient MRD negative before you transplant? And that is a question we always ask ourselves, that we should have a patient to transplant. whether MRD negative or positive. Don't make the patient go away, or don't kill the patient with too much chemotherapy before you start transplanting. So if they are not MRD negative, what we do is what we call a sequential transplant. We cytoreduce and then we give the graft. So Jamie was the first. My experience was with Jamie Kavanagh, Professor Jamie Kavanagh at the Barts Hospital, where we started doing a sequential cytoreductive therapy before a reduced intensity conditioning allogeneic transplants. Results were not very good. The Hammersmith protocol used the Flamser-Rick. Again, it was a German protocol, a little bit modified. We don't have Amaserkin here. These are the data showing that the relapse rates are definitely better if you use the Flamser-Rick protocol. The leukemia-free survival is also a little bit better. Now, this is very interesting. It came in the journal of, I think, the ASTCT journal, TCT, very recently, where they have used melphalan as a myeloablative agent and then do a reduced intensity transplant with flubu here. Now, again, you were seeing almost a 50% relapse-free survival, which is not bad in this group of patients who are MRD positive. So here you have to step back and ask yourself a question that if you're ready to do this kind of sequential transplants, what do we really need a proper MRD negativity, at least in AML, before we go into transplant? Can we separate GVL from GVHD? I think yes, we can. And especially with a Clinimax machine, we can do it with not too much of a problem, where we take out your CD19 and TCR alpha beta cells, and we add back a CD45 RA negative cells to give rise to better GVL effects. And here, this is just a platform. On this, you can give NK cells. On this, you can give Treg cells or take out Treg cells. So this serves as a platform for further cellular therapy. Now, this is a question which has been asked from time and time again, that is there a threshold dose for CD34 positive cells? And, most trials says yes, but some trials says no. And what I would say is that I would contradict myself and here for the presentation and would say that definitely when we are practicing, we are under the tribunal of jurisdiction. So I would definitely say that yes, keep in mind a threshold of CD34 cells. We really don't want to lose our right to practice also. So what we do is we, for our allogeneic transplants, we give them plerixafor, the donors, after written consent as a part of a trial it was. And what we see is that we increase their CD56 bright cell dose quite a bit. And this gives rise to not only a lot of NK cells in the graft, it also increases your plasmacytic dendritic cells in the graft, making your graft almost similar to a bone marrow graft in regards to graft versus host disease. Now, we have obviously written up this paper and sent it to an abstract to ASTCT, which has been accepted. So post this abstract, we hope to write it down as a paper also. But we can see that the CD56 counts go up. So we don't face a problem with the threshold dose of CD34. We do have quite a big doses. We do give quite a big doses. We'll come to the CAR T cell scenario. And there are quite a few CAR Ts here. We have used maximally this CAR T called Oxycart. And we have used a CD19 and a CD22 dual CAR. Along with that, in myeloma, we have generally used a BCMA and CD19. Some of our patients who have had a CAR T in our institute here. Now, this is a very interesting case, which again, we have written up as a poster and been accepted. So this is a 52-year-old female who had a relapsed refractory DLBCL, and we treated her with a CD19/22 CAR T cell therapy, CRS grade 2. Everything was going fine when she suddenly drops her counts, and we didn't know what it was. There was severe aplasia, and it was a parvovirus B19 positive. No HLH was seen. Even now, the patient is in complete response. So we tried to find out why patients have cytopenias post-CAR T. And this was, again, one of the recommendations that we find out, which is very useful to learn. But one thing is that you need to think above this, because there was nothing in this which matched our patient. And what we tried to do what people do. We do collect autologous stem cell before CAR T in our institute. We even gave that. Nothing else. Nothing happened, and the cytopenia persisted. Now, this is a graph there. So what in the flow cytometry, what we found that there was an NK cell clone which was coming along. And the whole exome sequencing showed a TET2 mutation. So this is a NK cell clone which is coming along. And if you treat it, and we treated with low dose subcutaneous methotrexate, the patient has done well. The white cell count is now almost in normal levels now. She's a little bit anemic, though, with a hemoglobin of around 7.5 to 8, not needing transfusions, doing well otherwise. But this shows that, apart from what you have in your recommendations, if you keep an open mind to all the other possibilities, you really need to find out what causes of this. And this is where, you stop and say that maybe it is time that we also write recommendations, and we are doing that, maybe a little bit more. So this was the takeaways from the CAR T case. It is difficult to formulate guidelines in this scene because, the science is evolving so rapidly. So at this point, you trust your instincts, trust your knowledge, your training, your instincts. And most of the time, the educated guess that we do is definitely better than following literature. So those are the conclusions, and I am going to stop here. Thank you.
Thank you, Dr. Jaydeep. An unusual talk. Enjoyed listening to you. You are an unusual person, and have given a lot of food for digesting, a lot of food for eating. I'm sure that people are blessed to listen to you, and we should have opportunity to listen to you more often. Originally,
Thank you, sir.
and yeah, it's great. I wish we have opportunity, and you give us those opportunities to listen to you more often. And I'm sure you'll do that. So let's have a bit of question answer. Yes, Dr. Krishna, go ahead. You are muted, or we can't hear you, Dr. Krishna. No, you're not muted, but we can't hear you. Anybody else has a question meanwhile? Nobody wants to challenge Dr. Jaydeep on his original thoughts. So it's wonderful, really, Dr. Jaydeep. First of all, you challenged the guidelines, and one thing I fully agree with you. The guidelines are for the trainees, and you, as the boss, need to sort of manipulate them, individualize them for each patient. So that's just like a framework around which you modify your thing based on. But no two patients are similar. So you're absolutely right about the guidelines. So yes, when we were learning, guidelines are fantastic. Even today, when you read guidelines, you get some kind of information. Your second comment I enjoyed was, today the research is pharma driven. So there is bias. One statement that I enjoyed reading was that the maximum tolerated dose becomes the clinical dose. So it is a nice money-making business. Give the highest possible dose to millions of people across the world with all its toxicity, though half the dose or one-third of the dose was also effective, which classical example is chronic myeloid leukemia, where the doses have come down by half or one-third with equal results. So that was a second very important comment which I enjoyed. Third, of course, related to your transplant innovations and the CAR T comments. Wonderful, wonderful, Dr. Jaydeep. Be more often with us, not only as the web meeting, but also in person. And I'm sure both seniors and juniors will benefit from you. Um, please come on with your questions. Dr. Krishna, can we hear you now? No, we can't hear you now also. Anybody else? Gopinathan, another very brilliant guy around.
Morning, sir.
Yes, brilliant.
I mean, I really enjoyed the lecture very much.
Thank
Ask
you.
questions. You
Yeah.
must be having a lot of questions.
Yes, sir. Sir. So the first question that I have is in mud transplants, the current protocol is to use ATG plus CSA methotrexate. Can we kind of do it as a dual prophylaxis approach of reducing PTCY to 35 and doing ATGs all at a low dose of almost 2 to 2.5 mg per kg? So what's your take on that, sir?
Shall I?
Yeah, yes, sir, please.
Okay. So, first of all, let me tell you, I haven't done a mud for a long time. Almost 1.5 to 2 years, we are doing haplos more than anything else. But saying that, I personally feel that reducing the ATG dose in mud is a possibility. And definitely we can think about it, and we have done it. And it doesn't cause too much problems. In fact, it might be better off in the high-risk diseases if we are thinking of reducing the dose. Secondly, about the PTCY, I personally find that reducing doses of PTCY, especially in high risk of graft versus host disease, having lost patients to grade 4 GVHD, I'm very skeptical. Saying that, what has happened is we have developed a kind of a thing where we have substituted 1 day of PTCY with 1 day of bendamustine. So on day plus 3, we give 50 milligram per kg body weight of PTCY, whereas on day 4, we use a 90 milligram per meter square of bendamustine. Now, many of the effects of like cardiotoxicity, VOD, and all that has gone down, though I find that the level of CRS is a little bit high. Again, this is in the poster phase right now. It should be published. But there are other groups in India, for example, Manthan and Professor Velu Nair at Ahmedabad. They have changed both their days of PTCY to bendamustine. So if I am skeptical about reducing doses or equivalent doses of PTCY, ATG definitely we can reduce, or maybe in some of the very high-risk cases, even think of omitting. If it's a 10-by-10 match, you mean?
The second question that I have is in a case of high-risk MDS, particularly when we have the low blast category, when we have blast less than 10%, what is your take on taking up directly them for transplant, or we need to do some cytoreduction and then take transplant? I think you did bring about this in your talk as well.
Again, again, these are things which there is no right or wrong answers, and that is the whole basis of the question. I'm really glad that it is making you think that way. But what I would definitely say is that if in a low risk MDS, if the patient has been transfused many times, be careful of the graft failure if you're not giving any chemotherapy. The chances of ABO mismatch, the chances of too much DSA and all that is there. But otherwise, I don't see a place of giving chemotherapy in a low blast MDS. Yes, I would be worried about graft failure in this patient, especially in the haplo and the MUT setting. And I would definitely think of giving a proximal ATG in this case to prevent that more than anything else.
Yeah. Right, sir. The last question maybe I have is a young boy, a 17-year-old boy, kind of transplanted elsewhere, but in 6 months had a graft rejection. He had a sibling as the donor initially. It was a 10-by-10 match sibling transplant. But then the donor had mobilized very poor stem cell quantity. It was only 3.8 millions or 4 millions. But then retrospectively, when we revisited our center, when we checked, he had a RUNX1 mutation. We are also checking the donor for penetrance. Now we are kind of advised him to go for a mud transplant. So now the current issues with the recipient is already he's having heavy iron overload. He's having ferritin of almost 5,000, and he has frank conjugated bilirubin. Also, he has some degree of residual colonic GVHD. So it's almost 8 months from the initial transplant. So how would we ideally condition or safely condition this patient?
So it's a very difficult case. First of all, when the donors don't mobilize, one of the things that we look at is whether there is a germline mutation there or not.
Yeah.
And definitely, most probably, this is what has happened. Now, if you're trying to do a transplant in a patient with a patient with active GVHD going on, you're basically looking at not a one-way but a two-way alloreactivity, which might happen. So here, definitely a reduced intensity or a non-myeloablative immunologically kind of a base transplant. So a lot of ATG. You would be worried about CRS also if you're doing a MUD, not a haplo. Okay, so unlikely that CRS will be a factor, but definitely a lot of ATG with a flu trio, maybe. I don't know, anybody else might have some other ideas, but immunological based transplant where we suppress the immunity as much as possible rather than myeloablate should be the way forward in this.
Thank you. Thank you, sir. Thank you so much.
Thank you, Gopinathan. Yes, Dr. Krishna.
Hello, can you hear me now?
Yes.
Yes, we can hear you now.
Okay, thank you. Thank you for a very exciting talk. See, actually, I have a practical question. The post-transplant monitoring, we do chimerism as well as for MRD in a malignant transplant. Sometimes you don't get a concordant results. You get sometimes a full chimerism and a small MRD creeping up. So like you, I am also questioning when you have a full lymphoid chimerism and when you give DLI on the top of it, will it work? When in the context of a full chimerism and a MRD positivity, giving additional DLI to make 100% to 110%, does it work or is there any other mechanism operating?
So it's a very difficult situation, and that's why we advocate that you do everything to look into MRD post-transplant. Chimerism, your NGS, your flow cytometry, maybe all three at the same time. Now, it depends on what kind of disease also we are talking about. If I'm talking about a CML, then maybe, DLI will have a much bigger role to play. Though theoretically, if you say that it's 100% chimerism and what else was the DLI going to do? I completely agree with that. What we tend to do is in the AMLs, when we have this, we definitely put everybody on azacitidine maintenance. And what happens is that it increases the amount of antigens on the surface of the cancer cells for your lymphocytes to act against that. And a few people and some experiments have tried using a little bit of PD-L1 inhibitors also in such cases, but it is playing with fire. So I would suggest that, if you have a case like this, then maybe wait off with the DLI if it is not a CML or a chronic disease, which is very amenable to the cellular effects of lymphocytes. Azacitidine is a good choice to think about in these cases, and drugs which increases your antigen presentation. So you think about those first, and if you can get rid of the MRD with that, very good, before your DLI.
Yeah, thank you. Thank you so much. I got a good insight. Do you always do a split chimerism?
We tend to do a split chimerism, at least the T cells. I think it gives us some information a few days beforehand compared to a whole blood chimerism as to what is happening to the T cell repertoire.
Okay, thank you. So I'll try it azacitidine definitely.
Thank you. Amit?
Yeah, thank you, Dr. Jaydeep. Wonderful talk. I just wanted to add on with what Dr. Gopinathan just said. If the patient is match sibling, full match sibling, 10 by 10 match, For example, in case of, for example, CMML2 going for a matched sibling stem cell transplant at 52 years old, received about 20-30 units of PEC cells, heavily transfused. Is ATG, adding ATG has any benefit or role in this? Because we are already doing 10 by 10 match. And so how ATG is going to help much in preventing the graft failure?
Very true. It's depends on whether you've got your this again, we don't know what is going to give rise to a graft failure here. Is it going to be a very high level of cytokines into interferon gamma or TNF alpha or that? If we think it is, then maybe adding ATG plays a role, because you definitely have lower CRS levels there compared to if you don't give ATG. But that is a situation more in the haploidentical setting rather than the matched sibling setting. So in a matched sibling setting, I don't think giving ATG in that way will prevent graft failure as such if you are antibody negative. But remember that we are only testing for some of the HLA antibodies. There might be so many antibodies that we don't know. So if you say that we are going to do it and give ATG, I don't think anybody can point a finger at you and say that you're not doing the right thing. So it might be just safe giving ATG, provided the patient can take the infective kind of prologues of ATG also.
Thank you. And is there any concept of low dose ATG?
We use a 2.5 milligram per kg ATG even in the haplos before PTCY. Definitely, we don't need any more. Apart from that, if they are not, thalassemics or an aplastic, where I would give them some more ATG. But at 2 to 2.5 milligram per kg body weight ATG is good enough.
That is the lowest dose, not lower.
That is the lowest dose.
Thank you, sir.
Thank you.
Yeah. Dr. Akshay, you'd like to read out your question yourself? Akanksha, are you there? Okay, Dr. Gopinathan.
Yes, sir.
Acha, yeah, sorry. Go ahead. Dr.
Yeah, thank you, Joydeep sir, for that wonderful talk. So just a couple of questions related to high risk AML and MDS. So I would just like to know that, whether do you practice giving just triosulfan in all your patients, or are there, patients where you would prefer a flu-bu based protocol? I mean, considering we don't have the, the busulfan levels readily available. So do you prefer flu-bu based protocol over flu-trio, or
Yes.
what is your practice?
So again, the practice depends on a lot of issues, including, we kind of do a cash-based, evidence-based practice rather than just evidence-based. Few
Sure.
things about triosulfan. One of the things about not using busulfan is, you have rightly made out that not having levels, though IV busulfan is definitely safe compared to oral busulfan. Secondly, your patient selection has to be very good. Thirdly, if you see that a patient, what we have done is that we have collected around 32 or 33 parameters, and we can predict a risk score for VOD before transplant. Again, this paper is published in PLOS One, and we have sent an abstract to ASTCT. So with that, we are seeing that we are being able to accurately predict the VOD risk in patients. And if that is so, definitely, if it is high, definitely we are not using busulfan. Triosulfan, on the other hand, we really need to understand that the triosulfan, the imported triosulfan and the generic triosulfan we have are absolutely different drugs. And we have to be mindful of the fact that there have been a little bit more relapses with the generic triosulfan. So one has to be careful with that. And after 2 or 3 relapses, we kind of have started going a bit cheaper and using just a flu-mel with a bit of TBI transplant rather than using flu trio or flu boo at all. So again, your flu mel transplant is cheap and is well tolerated in the majority.
Okay, so that goes for even the young fit patients.
Yes, yes. So you give them a little bit of TBI, depending
Okay.
on how much they can take it. In fact, for the young fit one who don't have any extramedullary disease, we have
Yes.
gone to giving them 6 to 8 grays of total marrow irradiation rather than total body irradiation, and they tolerate it very well. The results are good.
Okay, sure. And sir, my second question is regarding your practice of DLI. So, are you giving prophylactic DLI starting at 3 months, or I mean, what is your protocol for
Yes,
giving
so
the DLIs?
if we are doing a TCR alpha beta depleted, we definitely keep some MDLI along with us, and we are
Okay.
using it prophylactically. Now, for the haplos, I would not use a normal DLI prophylactically. That again is playing with fire. But definitely, if we have MDLIs, I can use it prophylactically post allogenic transplant as a maintenance.
Okay, sir. Thank you so much.
Yes, Gopinathan.
Sir, in that continuity, I just want to understand few things. So you said ATG in haploidentical transplant, just immediately pre-graft. So we depend on this PTCY because we need good amount of allo reactivation from the graft. So that's what PTCY takes care. So if we do ATG just before the graft infusion, and whether we will be giving that much amount of alloreactive component for the PTCY to act. So
PTCY, we do it proximal rather than distal. So we do it around day minus 11, day minus 10, that kind of time. So, doesn't really make any difference because anyway, ATG remains in the system for around 15 days. Now, the use of ATG in haplo has really come from what we say is the Chinese people, the Beijing protocol and all that. And again, do we find really too much of a difference whether we use ATG with that or not? I would say that if in a case where we are worried about graft failure, using proximal ATG definitely helps. But again, there is no right or wrong to it. We have done so many haplos without ATG also, and they've worked well.
Your take on CAMPATH based approach in this kind of complex transplant, second transplant, where we anticipate too much of graft failure. What is your experience of CAMPATH?
So CAMPATH, we used to do a lot of CAMPATH-based transplants, especially in the UK. Unfortunately, we don't get CAMPATH that easily now. But saying that, I think you need to write to the company saying that and get it specially made for the patients. So whatever it is, CAMPATH definitely increases your infective risk, and CAMPATH is much, or I would say CAMPATH definitely gives you more suppression of immunity than ATG, especially if given distal in the transplant. But again, I myself, we did, this was not in the haploidentical setting, and this was not with PTCY. We did an audit of around 26 patients comparing ATG and CAMPATH. And what we found out in that is that the overall survival is definitely better with ATG compared to CAMPATH. The relapse-free survival is definitely better with ATG than CAMPATH. So, but the incidence of graft in those 26 patients, we had around 2 graft failure in the ATG group, whereas there was no graft failure in the CAMPATH group. These are all CML patients, by the way. So, definitely more immunosuppressive than ATG. It is going to give rise to more infections, especially EBV infections. So in a second transplant, be mindful of that. But it is going to suppress your immunity, and you most probably will have better graft function compared to ATG if you use both.
Any recommendations on dosing of CAMPATH?
I will have to check, but we give it for 3 days as far as I remember. I'll have to check, Dr. Gopinathan, on that.
No problem, sir. So the last question may be the triosulfan. We see papers reporting 10 gram per meter square, 12 gram per meter square, and 14 grams per meter square. When we use it for adults, what do you feel, or from your experience, what is the optimal dose of triosulfan?
See, I personally feel that a difference between a 10 and a 14 is minimal.
Meaning,
So whether you give a 14 gram per meter square of trio or 10 gram per meter square, the effects we get is almost the same. So, it doesn't have that amount of reduced intensity regime if you reduce it by 4 grams per meter square. That's my personal opinion. But you need to tell me what you feel about it.
sir, for the couple of patients that I have used, I used only 10 gram per meter square only for adults. For
Right.
young TALs, maybe are gone up to 14 grams per meter square. For them, it kind of managed the toxicity, and the graft retention was also good. I couldn't see a lot of mixed chimerism and all, but for adults, predominantly, when I used it in PIDs, MDS, I just restricted myself to 10 grams per meter square, and it kind of worked well. Even the long-term chimerism, I would say up to 1 year, it wasn't mixed. It was more of a sustained chimerism.
Okay. Good. No, I've generally used a 14 gram per meter square, but I've definitely something to think about.
Sir, you're on mute, sir.
Another question? You have raised hand sign. Amit, you have a question?
No, I don't have a question.
Fine. So in that case, Joydeep, thank you very much.
Thank you.
The lecture, wonderful discussion also. The guys are also thought-provoking. Their questions were fantastic. And your answers were equally thought-provoking. Very good interaction. So be with
Thank you.
us often. And thank you. We go on to the second lecture now. It's my pleasure to introduce our second speaker, Dr. Neeraj Siddharthan. Doesn't require introduction to group present over here. It's just the formality. He's clinical professor and HOD, Department of Clinical Hematology, Amrita Institute of Medical Sciences, Kochi. He wanted us to be very brief, so I have been briefest. He's going to lecture on very, very interesting molecule which has become available to us for last couple of years and has been a very useful tool in saving lives. And that is inotuzumab in the treatment of relapsed refractory adult B-cell acute lymphoblastic leukemia in Indian context. So we will be having his experiences. Over to Neeraj.
Good morning, everybody. Thank you very much, sir. Thank you so much for this opportunity. It is a great honor to be part of MHG educational activities, and a great honor to be speaking today on this topic. So I really enjoyed listening to Dr. Joydeep. So I guess I have a difficult task now to come after and speak. So as you mentioned, sir, the inotuzumab is a very interesting molecule, and so we need to try and figure out how best we can use this in our practice in India. Okay, so I hope my screen is visible.
Yes, Neeraj.
Thank you, sir. So my disclaimer is that I'm not an expert in inotuzumab, but I have used inotuzumab alone and in combination, and have seen both sides of the coin, the good part and the bad part, and for this presentation of financial interest to disclose. So here, if you look at the evolving treatment landscape of B-cell ALL and see the drug approvals that has happened over the last few years, we can see that the blinatumomab came quite early, and then you have different approvals for blinatumomab, and then which has been the molecule of course which came initially. Here you can see the inotuzumab first coming here in 2011, and then there was an Innovate trial which compared inotuzumab after the phase 1. It was the Innovate trial which compared it with the standard of care in the relapsed refractory setting, and then finally led to the approval. So inotuzumab, even though we say inotuzumab, if you try to know the molecule, it is a combination. It is inotuzumab with osagamycin. So is inotuzumab, as we all know, is a monoclonal antibody which is targeting CD22. So ALL blast is expressing CD22. So it will be able to bind to that. There is a linker, and then it is linked to the anti-tumor antibiotic called osagamycin, which we'll come to what is osagamycin, which will actually go into the cell and do the DNA damage. So, but before we go there, it is important to know that, CD22 is expressed in many B cells, including the lymphoma cells. But this was a early result which came in 2013 that inotuzumab initial drug trial in lymphoma suffered a failure. So I was interested in trying and looking up what this molecule was and why it has got such mixed results. So as I mentioned, the calicamycin, osagamycin is chemically derived from calicamycin, and the calicamycin is an anti-tumor antibiotic which is derived from this species of a microbe called Micromonospora echinospora calicasis. And the name comes from a place in Texas where you have these calicate pits. And it is from this that the antibiotic, this was finally derived. So calicamycin, we know, it has been used in another antibody drug conjugates. And in inotuzumab, you have an N-acetyl moiety added to it, and then there is a cleavable linker. So this is a very powerful DNA damaging tool. So what happens is, the inotuzumab is loaded with multiple molecules of N-acetyl calicamycin or osagamycin, so that it is 100% conjugated. So how does this act? CD22 is expressed in most patients with B-cell ALL, and inotuzumab binds to CD22 on the cell surface, and then it is internalized, and calicamycin is then released inside the tumor cells. And then it is more potent than the other cytotoxic agents. It binds to DNA in causing the double-stranded DNA breaks, and it is followed by apoptosis of the tumor cell. So if we look at the that era, what was the chemotherapy options prior to inotuzumab? You can see that almost always without a transplant, following the chemotherapy, you had a FLAG-IDA, FLAG, CAG, and clofrab in there. And without a transplant, almost nobody got cured. And with transplant, a small percentage of people with relapsed refractory ALL got cured. So this was the pivotal trial results where the inotuzumab was compared with the standard of care. And the dosing here was 0.8 on the first week, and then 0.5 on the second week, and 0.5 milligram per meter square on the third week. And if you look at the results, it showed a very good outcome compared to the standard of care, almost in all subgroups, whereas you are stratifying by the risk stratifying factors or other patient characteristics. Almost in all those groups, you saw a clear pattern in favor of inotuzumab in this forest plot. And if you look at these are the overall survival and progression-free survival graphs, and you can see there was a clear improvement in the progression-free survival for those patients who had taken inotuzumab. And then the further sub-analysis looked at if you are MRD status and if whether you underwent a transplant after INO. And as you can see, the people who performed best seem to be having a MRD negative and who had undergone transplant. Other thing is this drug can be given as an outpatient when given as a single agent. And in fact, if you look at the hospitalization days or number of days of hospitalizations when compared to the standard of care chemotherapy, it is much less. So as a patient, you could spend most days, out of hospital when compared to when you're taking the chemotherapy. But the problem identified, these are the adverse events, and as all of us know, this trial identified a subset of patients who developed veno-occlusive disease, which most of them had severe grade 3 or more toxicity. So, and this was in all patients. And then there were subsequent publications which looked at the VOD in patients who underwent transplant. Now, if you look at the patients who undergo transplant, the VOD multiplies actually from 10-15% to 30%, approximately 30% in patients who undergo transplant after taking inotuzumab. And many of these patients, the VOD is fatal, and they may die due to multi-organ failure as a consequence to the VOD. So how does this VOD happen in inotuzumab? So we have this figure depicting the hepatic sinusoids, as you can see here. And so it is very rich in vascularity, and you have the hepatocytes bordering it, but then there is an endothelial cell covering the hepatic sinusoids. So this is a histopathological figure, and what happens in this is hepatic sinusoid, and then you have this endothelial cell here. So the red blood cells are here. Your drug, as you can see, the toxins in the drug is the osagamycin, and then the osagamycin comes in contact with the hepatic sinusoidal cell, probably through macrophages. And then the endothelial damage occurs, and you have approximately the hepatocytes, and which results in hepatocyte injury also. So this is not new to inotuzumab. If you look at history, and this is reported in Blood more than 2 decades back, similar problem arose with another important drug called gemdisumab, anti-CD33 antibody, which was linked to osagamycin. And people reported VOD from different centers, and the drug was taken off the approval. So the pathophysiology of VOD is that any of these toxins can cause damage to the sinusoidal endothelial cells, and then endothelial cells will slough, and then it may obstruct the blood flow and then result in hepatic necrosis, and then clinical manifestation of hyperbilirubinemia, jaundice, and you have a portal hypertension, ascites, and fluid retention. So how does osagamycin cause toxicity? So as in any drug, there are different, in the kinetics, if you analyze, there are different things contributing to the efficacy and different things probably contributing to the toxicity. Like you look at minimum inhibitory concentration, then you look at the area under the curve, the Cmax and all that. So this is for antibiotics, but osagamycin is essentially an antibiotic. So here what matters mostly is the Cmax, which for the toxicity. If you have a higher Cmax, and then that results in a higher toxicity. So which is why we need to be very careful with the way we are going to dose our patient. And oxagamycin is also having a very narrow therapeutic window. So if you dose it too low, it may not be effective. I mean, if you dose it too high, it will be toxic. And if you have to play around with a very narrow range. So the next question is, can lower doses be effective and less toxic? If it is going to kill patients, should we use lower doses and will it be effective? So this is a recent publication in Hematologica. Early this year it was published, and it is from different multi-centers across different continents. So they looked at the approved dose and lower doses of anotuzumab in adults as a phase 4 study. And they did initially a run-in phase for a 1.2 milligram per meter square per circle, and then did a randomization for 40 patients each with 1.2 and 1.8. So this was the incidence of toxicities in both the cohorts. If you look at the patients reporting sinusoidal obstruction syndrome, it was much similar in both the cohorts. I mean, the lower doses actually did not result in lower incidence of sinusoidal obstruction syndromes. But if you look at the outcomes also, the outcomes were more or less similar when using both the doses. So this is the PFS curve, and the run-in initial dose of 1.2 milligram per meter square is here, and in the randomization you can see the blue line there, slightly overriding that the green one, which was the higher dose. So definitely at least in this study, it didn't appear that the lower doses were less effective, with the point which Agrawal sir and Dr. Jyoti were making earlier. So the next question in our mind was, okay, anotuzumab in single agent is effective, but can it be combined with chemotherapy, and will that be effective? So a lot of work has come from MD Anderson on this, and so here one of the earliest papers were published in JAMA in 2017, where salvage immunotherapy with anotuzumab combined with mini hyper-CVD was tried for pH negative relapsed BALL. Sorry about this slide. But I think I wanted to highlight this part of the graph here, where they had done a comparison with historical comparison. This was not an RCT, but a historical comparison with INO alone here and the INO mini hyper-CVAD, and tried to show that the INO mini hyper-CVAD was working better for a better overall survival. But again, a point which Dr. Joydeep was making, and if you want to try and question things, in the main paper, you don't find this. This is a supplement of in this paper. When it was combined with mini hyper-CVD, you can see the comparison for anotuzumab alone, the VOD is 6% here, and then for hyper-CVD plus anotuzumab, this one is 15%. But this obviously didn't come out in the main paper, and I had to dig out the supplement to find this. So even then, it was reported that when you combine with chemo, you may have a higher incidence of VOD there. So subsequently, in the MD Anderson, they tried and modify the doses. They still tried anotuzumab combined with chemo, and then they added blinatumomab also. So in this figure, you can see that initial dose was starting off with the 1.8 milligram per meter square. Then they reduced it to 1.3 milligram per meter square, and which is 0.8, 0.5, and 0.5 that we use for this one also. And then there was a reduction further from the 1.3 to 1 milligram per meter square. So here you can see that there's mini hyper-CVAD methotrexate with Arasi here, and then the maintenance here. And there were 4 doses of anotuzumab given here. And then there was this amended dose also. Very interesting to point out the second one, which is here, where you are actually combining with hypocivad with Arasi here, but then you're adding anatuzumab here during the Arasi methotrexate arm in a split doses, lower doses, and then giving it the blinatumomab here, and then adding anatuzumab during blinatumomab combinations, and then continuing POMP, the maintenance alternating with blinatumomab, and trying to see if the outcomes are improving. So, but as you can see here, from 1.8, the dose comes down to 0.6 here, and that is something which has happened with the clinical learning of the toxicity of inotuzumab. At present, this is a review article by Kantarjan et al. In 2000 last year, and it was looking at the different clinical trials that are ongoing. So now I think now that we have tried and learned how to use this drug, and people are now trying to combine it with different agents and use it not only in the relapse setting, but many of these trials, although today's topic is relapse refractory, if you can see many of these trials, they are actually giving anatuzumab or trying to give anatuzumab upfront and not in the relapse setting. So just a small case to stimulate our thoughts. A young patient with Ph negative BALL and then MRD positive after salvage is considered for allogenic transplant, and anatuzumab is available. So would you use a single agent or a hypocivad combination, or would you use the approved regimen, reduce or fractionate the dose to mitigate the risk, and how would you do the VOD prophylaxis, and how would you do the transplant conditioning? So talking about the transplant, and you can see that if you use the anatuzumab in salvage 1, you have a lesser incidence of VOD compared to where you use in salvage 2, where you have a higher incidence of VOD. Vis-a-vis, also, if you're going to transplant the patient in the first instance, then you may have a lower incidence of VAD where you salvage the patient after the second, transplant the patient after the second salvage. But as you can see, when you transplant after anatuzumab, the risk of VOD really, really goes up. So if you really want to go ahead and transplant, how to mitigate the toxicities? So basically, it is also known that Dr. Joydeep was mentioning, there are scores which actually tell us the risk of VOD, but dual alkylating conditioning regimens are significantly associated with an increased risk of VOD, and that is recommended to be avoided. And the recommendation is that we stick to 2 cycles of anatuzumab. And if total bilirubin is high, then prior to the transplant, then we have to be very careful, especially the transaminase is also, we need to monitor it very careful, and that will portend an increased risk of VOD there. So it is recommended that drugs like ursodeoxycholic acid may be given to all patients who have been exposed to anatuzumab to prevent VOD. So in summary, who would benefit from inotuzumab treatment? Patients who are CD22 positive, especially in salvage 1, and it is a very potent drug. Unlike a blinatumomab, which is not very potent but acts in an MRD positive setting or a small volume disease setting, in a high blast percentage case, this is a good drug to use. And if the patient has not had a previous transplant but eligible for a subsequent transplant, you could still use it very carefully. And you need to be cognizant that the patient has to have a good liver function test and no previous history of a alternate liver disease, which will again predispose to the liver injury. And then the dual alkylating agents, definitely you should try to avoid. Moving on from a young to older patient, if you don't want to transplant, is there any benefit? And is there any increased risk of VOD, especially since this is a costly drug? So that question remains to be answered, but I'll try to see take you through some other settings where we may find it, whether to use this drug or not. So one of the settings is, of course, if you have a patient who has a post-transplant relapse, and then there is some data on the patients having a post-transplant relapse, and if you use it quite early, then the risk of VOD is quite very high. The next setting is if you have extramedullary disease other than CNS, is it useful? It looks like it is still useful when you use the drug in the extramedullary relapse. And many patients, at least half of them underwent, in this abstract, they reported at least half of them achieved CR in this patient. But we need to know that this is a big molecule, and we have a blood-brain barrier which is quite tight. You have tight junction. So because of this huge molecule, it is not entering the blood-brain barrier. So this is not a good drug if you want to use it in a CNS relapse. So how many cycles you need to give? Generally, the regulatory approval is for 6 cycles, and most patients now receive 1 to 3 cycles, and if you are planning for a transplant like that or CAR-T. So talking about CAR-T, the next case scenario is about a patient who is planned for CAR-T. So is it safe to move directly from inotuzumab to CAR-T, and do you cap inotuzumab cycles in this setting? So this is a paper which came 2 years back in ASH as a poster abstract, which looked at outcomes in patients who were treated with inotuzumab versus who were not treated. So those who did not respond to inotuzumab when you go for CAR-T did not have a good outcome, compared to those who received CAR-T here and those who received inotuzumab and had a good outcome here, vis-a-vis those who didn't receive inotuzumab. That was the early result. This year's ASH, next few slides, I'll take you to this year's ASH. What is the update on this drug? So this was one oral abstract of, which looked at the inotuzumab bridging for those patients who underwent CAR-T. So it showed that there is a better pre-infusion tumor burden reduction when you compare to other agents used for bridging therapy. And so there was a higher conversion to low disease burden and positively impacting EFS. There is a, despite the lower CAR-T expansion, they also looked at, because of the increased proportion of the SCMT cells in ano-treated patients, which kind of, impacts the CAR-T expansion, but still those who underwent ano had a better results in this publication. Okay, so again, like in transplant, most centers, I think, would limit INO to less than 2 cycles before CAR-T to minimize hepatotoxicity. And inotuzumab as a maintenance regimen following transplant is, there was also another paper which got published in Blood Advances. This was a phase 1 trial, and they have used lower doses, 0.3, 0.4, and 0.5 and 0.6, once in every 28 days. And they have, initially 4 cycles were allowed, and then they had increased up to 12, and it was initiated between day 40 and day 100. So there were no instances of sinusoidal obstruction syndrome, and the maximum tolerated dose was 0.6 milligram per meter square. So this is something interesting. The toxicity was, of course, thrombocytopenia. We had tried in one patient, this one. So it's not clear what number of cycles would be safe and effective, but this is something I think people would pursue it and see whether we can reduce post-transplant relapse with lower doses of inotuzumab. Yeah, so this is another abstract which looked at whether we can give inotuzumab plus or minus blinatumomab in relapse refractory setting and not do a transplant. So all these years we have been thinking we should do a transplant. This again is from MD Anderson, and the patients received, some of them received INO and blina, some of them received INO without blina, some of them received blina without INO, and some of them with chemo with blina and or INO. And so there was those who, in the short, for a 4-year RFS was very similar between those who underwent transplant versus those who did not undergo transplant. This is kind of a heterogeneous cohort, but then still it asks this question whether we can salvage without a transplant, at least in some patients. Yeah, so then you have this, I'm sorry, yeah. Yeah, so, yeah, sorry. So, there's also another abstract which looked at the anotuzumab and blinatumomab for older adults, which are median age of 71 years. This is mostly in the upfront setting, not in a relapse setting, but I thought I'll just mention this paper because, again, this had a reasonable follow-up of 3 years and a reasonable EFS of 48%, where chemo-free regimen of both anotuzumab and blinatumomab was given. And again, here, if you look at the doses of anotuzumab was much lower at 0.5 milligram per meter square in 2 cohorts. And then for the pH positive ALL, there was another abstract which was looking at the combination of tyrosine kinase inhibitor, and this was from Dr. Wendy Stock's group there, and they used initially a C1 course where you had a higher dose of anotuzumab. And then there was a schema 2 where there was a lower doses of anotuzumab, skipped anotuzumab in the first month and used it in the second month, and then tried to use dasatinib plus dexa plus pomp, and quite interesting results and good MRD rates. So this is also a new direction. We have seen blinatumomab with TKIs, but now we are seeing anotuzumab with the TKI, and it will be interesting to know more about that. Finally, the last publication that I'll review is also very interesting. It is about venetoclax plus anotuzumab. So venetoclax, the only thing which was not used with was anotuzumab. So this is from Dana-Farber, and they have looked at a 3+3 design for escalation of venetoclax, and one group had received 200, another group had received 400, and there was very good CR rate of 95%, and of course, a very good MRD negativity. So a good number of patients with about 20 of them. So these are a few Indian publications, small numbers. Narendra's paper had the largest number of 32 patients. Then Vivek Radhakrishnan, Dr. Bora, and Dr. Ramalingam also published from the Indian context. And mostly what we see is that anotuzumab monotherapy is quite feasible in the Indian context, and durable remissions, MRD negativity are achieved. And all of them have reported caution with the POD. So to conclude, I would say anotuzumab is a very powerful drug with a narrow therapeutic index, highly effective in CD22 positive patients with a rapid cytoreduction, very high MRD negative rates and CR rates. And this calicamycin payload causes profound DNA damage and anti-leukemic effects, but collateral injury to sinusoidal endothelial cells has to be very carefully seen. It's a dose-limiting toxicity, and risk increases with higher Cmax and cumulative dose, and also subsequent allogenic transplant. Therapeutic success depends on dose optimization, timing, and intent. So where anotuzumab fits best in 2025, I think, is a bridge to definitive therapy like transplant or a CAR-T. CAR-T has a lower SOS risk, but the data is evolving. Cycling limitation is critical. Most centers would cap as less than 2 cycles. And lower dose fractionated schedules would reduce toxicity and reduce the endothelial injury. There is also evolving data on post-transplant maintenance. And non-chemo combinations data is evolving with TKI inhibitors, blinatumomab, or low-dose chemo and venetoclax. It is evolving, but it is promising. So I would stop saying that anotuzumab should be used early, briefly, and strategically, but never casually. Thank you.
Thank you, Neeraj. That was great. Early, briefly, strategically. Fantastic. The slide said it all. You covered it so nicely, broadened the utility of this wonderful drug. New molecules don't come every day. So the optimal use of an existing molecule in the best way, and your talk was full of that kind of discussion. right up to the ASH December this year. You updated us beautifully, and I'm sure that those who have not used this molecule or used it sparingly will be so much benefited by how to use it judiciously. No molecule is bad. It is bad when you don't know how to use it. So you helped us in using this very carefully and making the best use of it. So wonderful. Thank you so much. The Sunday morning was worth with listening to you. Let's have some discussion. Lots of friends are around. And of course, you can put in the chat box. There is a question in the chat box. Prevention and management, differentiation of post-CAR T, prolonged cytopenia. Prevention and management, differentiation of post-CAR T, prolonged cytopenia, how durable CAR T response compared to allogeneic transplant, how will you choose between INO versus Blino in the relapsed B-ALL setting? Okay. Okay.
I hope I got the question correctly, but in a relapse, I would probably start from behind and go forward. So in the relapse setting, how do you choose INO? INO, as I mentioned, is a very potent drug. So if you have a high blast burden, and so definitely you have a standard of care chemo earlier, and then you have blinatumomab, and then you have inotuzumab. And so these are the agents you choose. And assuming that we are dealing with a pH negative BALL. So if it's a bulky disease, I would choose, if there's a large blast percentage, I would tend to choose inotuzumab. If the CD22 expression is good, in the clinical trials, they say, more than 20% of CD22 expression, but definitely before starting inotuzumab, have a look at the flow cytometry plots and make sure that your CD22 expression is good. And also be careful about the liver function tests of your patient, and especially your pre-op serology, HB core antibody, and all that. Make sure that you're doubly checking that. If there is any alterations in the liver function test, make sure we address that before we decide on starting the inotuzumab, because most of the patients, this is something which is overlooked. Then it's the CNS disease. So CNS disease, if it's an isolated CNS relapse, there is pretty much no use of giving inotuzumab. So because it doesn't cross the blood-brain barrier. If there are additional features which predispose the patient to veno-occlusive disease, then I would maybe think twice or maybe modify the dose or accordingly. And the other question, of course, is how to choose between the inotuzumab or inotuzumab with chemotherapy, combination therapy, which is a difficult question because we may find increased remission rates if you add chemotherapy to the inotuzumab, but at the expense of having toxicities. Even when you're using the single or in combination, we must be cognizant of the Cmax, and even if the patient doesn't have a predisposing liver disease, we still should be careful with the dosing. So for example, if you're going to give the 1.8 milligram per meter square or 1.3 milligram per meter square a flat dose, or if you want to save the vial and give the complete dose, those are instincts I think we should restrict from, because a higher dose is not always safe. In general, we have a tendency that probably like we have used rituximab, many doses may be equivalent, but that's not the case with inotuzumab. We need to be cognizant that a higher dose may actually harm the patient. So that is something which I would think of when starting. And between the second question regarding choosing between CAR-T and transplant is, this is outside the perspective of this talk, but in both settings, I would not hesitate to use inotuzumab for transplant, but you have to be cautious with it. But in the CAR-T setting, in at least where we have used personal experience, and when we look at the literature also, the incidence of VOD is much less compared to the transplant. So we would be much comfortable using it in the CAR-T setting as against the transplant setting. If you're using in the transplant setting, then we need to modify, work on probably consider modifying your conditioning regimen and also giving ursodeoxycholic acid for the prevention.
Thank you. Thank you. Dr. Ashok Yadav.
Thank you, sir. Thank you, Dr. Neeraj. Good to see you from. I have been part of the CHG group and the MHG. Thanks to and knowing that you are there today. So
good to see you. So happy to see you.
Yeah. So my basically, of course, one child which we talked about, and we have been, infantile ALL, which are relapsed refractory, and especially if they had this baby, we used, in fact, analizumab, as you said, he used it very cautiously, along with the mini hyper-CVAD to induce remission, and then he could not undergo transplant. He had a relapse. And then we're trying to find CART for him that was experimental. So Dr. Gaurav helped us out. But the time it took was about 4-5 months gap was there. So we gave him actually almost 4 cycles of analizumab, and on the backbone of modified St. Jude maintenance of 16 weeks. Actually, he remained, unfortunately, the delay costed him that he had a further relapse despite 4 cycles of analizumab. And this was just to highlight, of course, it is a rarer, it is one exception maybe. He underwent CART, and subsequently you remember that I talked about him for going for transplant, which again happened at Tata Memorial. Akansha would remember. And this kid, post-transplant, of course, again, day 25, he had MRD positivity. Unfortunately, we managed to get revumenib for him because he came to 2A positive. This drug we got it from US and gave it to him almost 3 months. And sadly, the child is no more. But the point which Dr. Joydeep made, that guidelines are there, but sometimes you have to keep altering to suit your patients. And despite all pragmatic approaches in trying to caution parents, they do keep coming and insisting that what else. At the end of the day, a clinician who has to take a call has to balance out what the side effects would be and what is that therapeutic window, especially the window in terms of timelines also. So now with revumenib coming in, I'm seeing that maybe in KM2, which has been such a bad disease to treat, upfront some data if you have. If you can just comment about if there is any data which is on revumenib upfront in any trial. I actually didn't got the ASH book, but I have not seen anything. So revumenib in KM2 2A in positive disease, along with the upfront whatever induction chemotherapies we are using. Is there any paper or anything?
Dr. Ashok, I'm not aware. I'm not updated on it. So I'll certainly look that up, but I'm not aware. Yeah.
Okay. Thank you, sir. Gargwal sir. Of course, I'll try to be bored now. I'm back into again clinical. In armed forces, we keep switching between administrative and clinical jobs. So I'm back into clinical again. So I'll try to have more time to be there in your meetings, sir.
Thank you. Digambar.
Thank you, sir, for the excellent talk. I have 2 questions. First question is regarding one patient, sir, a 55-year-old female. She is pH positive ALL with high disease burden in the beginning. So she was given inotuzumab with mini CVD with the TKI, and post that she is now in molecular plus MRD remission. So now what will be your consolidation strategy in such patients? Will it be just inotuzumab with TKI, or what will be? And my second question is regarding the transplant in this patient, specifically regarding busulfan dosing. Whether will you reduce the dose of busulfan, or will you do the therapeutic level monitoring, or how will you go? Or only in the cases where you will use dual alkylator inhibitor, you will be cautious?
Yeah, thanks for that question, Dr. Digambar. So first question is regarding the consolidation strategy for this patient who is a 55-year-old and who has received inotuzumab plus TKI and then hyper CVD also. So it's a CR1, I believe, not a relapse setting. So I mean, mostly at our center, we try to see if the patient is fit and can be offered a allogenic transplant in CR1 in the pH positive setting. But if you're not able to do that, I mean, and then we would continue with the TKI for some of the trials look at giving TKIs for 10 years or so, but a long-term TKIs we would give. But if we are going ahead with the transplant, coming to the second question, and how would you be cautious? So it depends on, again, the cycles of anatuzumab that the patient has received and the time towards the transplant. You would generally try to keep about 2 months to 3 months, 8 to 12 weeks to the transplant from anatuzumab. And if it depends on if the patient, what kind of a donor the patient has, if it's are you going to plan for a PTCY or if you're planning for a dual alkylator regimen, I mean, we would not give any regimen with dual alkylator, be it for a post-transplant or pre-transplant. And busulfan, yeah, I mean, in ALL, we give TMLI if we are worried about TLI, the total marrow lymphoid irradiation. But busulfan, we have not given off late and for a very long time. So I would tend to, I don't know how others think, but I would tend to avoid busulfan here and maybe go because of the age, and if there is frailty, maybe try and see and come down on the toxicity by using a TMLI. Sir, you're not audible, sir. You're muted.
Can I ask you one question on this situation? So when you have achieved MRD negativity and the molecular response in a patient who is pH positive, treated with almost everything that you have in your armamentarium, you used TKI, you used hyper-CVAD, you have used inotuzumab, you have achieved what you wanted. Will you always transplant such patients?
The transplant comes into the discussion for sure, sir. I mean, we would definitely want to tell the patient that, you know, this patient has, even if the patient has achieved an MRD negativity and it's on all the possible treatments that we have given, you know, it still has a chance of relapse. So that I would definitely tell my patient. And I also tell, you know, the substantial risk of mortality and morbidity in a transplant. And I wouldn't push them to a transplant for sure, but I mean, the point is, you know, if they relapse later, you know, I want to make sure that I've mentioned that, you know, the transplant is an option, especially towards the older side, this patient, 55 years. Whereas if this patient was, say, 25, 30 years of age, I would probably be more aggressive.
Thank you. Amit, your question.
Thank you, sir. Hi, Dr. Neeraj. Wonderful talk, and the keynote what you gave was early, briefly, and strategically was wonderful. I want to know about the early part of yours, actually. So, for example, if a patient is a B cell ALL, after induction, the blast count is 6%. You are opting for transplant because after induction, the patient has failed induction, but the blast count in the marrow is 6%. So, would you like to go for INO straight away in that setting?
Yeah. So you're talking about an adult young patient, right?
Young patient.
Yeah, and who's fit for transplant. I mean, yeah, so only 6%. So that is something very interesting. So because, you know, it's not a, you know, the disease bulk has really come down. And so I know is a good drug. I mean, if you use it wisely, but here we have definitely other options. We want to make this patient MRD negative, right? I mean, that's the idea. Before transplant, you want to make it MRD negative. So you could use other alternative is blinatumomab. Even lower doses of blinatumomab of a 2-week infusion we have tried in such scenarios where you want to make the MRD negative. And I found it useful. The 1 week of a lower dose and another second week of a full dose. So that first week of a lower dose will take care of the CRS part and the second week of a complete dose, and then we have usually done marrows after that. Although the recommendation again is for 4 weeks, but for many reasons, financial reason and otherwise, sometimes we've not been able to reach 4 weeks for. But this strategy of using BLINA to achieve MRD negativity is what we have generally tried. Yeah, you could use inotuzumab for sure.
Thank you. And another question is regarding INO monotherapy versus INO in combination with mini hypersivate. When to go for mono and when to go for mini hypersivate?
Yeah. So if you look at how the mini hypersivate evolved, if you look at that slide which I showed, they started with a higher dose and found themselves with a higher toxicity. Although it translated into a slightly higher rate of remission when you do the historical comparison, and there was no randomized trial. So there's no randomized trial. So we have tried combination, but I mean, there are certain settings where you would try combination, I suppose, but most settings we would use a single agent.
And suppose if you're using single agent monotherapy, what should be your dose? And if you're using in combination, what should be your dose? And how will you fractionate the dose?
Yeah. I don't have a very clear answer to this, Dr. Amit, but if you look at some of the literature which has been reported, and certainly the problem is with the maximum dose of one. So you give, let's say 1.3 at the first dose, or let's say 0.8 at the first dose, and your patient characteristics. So I would definitely take into account the patient characteristics before I decide all this, whether it is a combination therapy or whether regarding the fractionation. So if I'm skeptical of, I'm in doubt, I would start with 0.5 milligram per meter square and then fractionate it 0.5, 0.5, and 0.5. There are instances we have gone below that also, but 0.5, 0.5, 0.5 at least, I mean, or 0.8, 0.5, 0.5, 0.6, 0.6, 0.6 also, 0.6, sorry, total of 1.2. So total 1.2 also has published literature is there. So, I mean, some patients we have given 2 doses only, 0.5 and 0.5. There was an abstract presented recently in I think Hematocon also, where they looked at only 2 doses of 1 gram and 1 gram, total of 2 doses. So I don't have a very clear answer, but I think lower doses do work, and it may help mitigate toxicity. In clinical practice, we tend to see what is the minimum effective dose that we can give rather than maximum tolerated dose.
Thank you. And my last question is regarding, you said that the SOS risk with CAR-T is much lower with INO as compared to for the transplant part. So is it, how much is the tumor debulking we need to do before going for CAR-T? Because whatever the literature what is available, that if you has a higher tumor burden, as such after CAR-T also you're going to have a very high CRS risk after CAR-T. So we are going to tumor debulk with the help of inotuzumab, right? So how much is required to go for a tumor debulking with inotuzumab to have a lower CRS risk after CAR-T? And number 1, and number 2, whether the tumor burden as such really predicts that you will have a lower SOS after CAR-T, because if you're reducing too much of tumor burden lower with INO, then whether that is predictable for getting a SOS after CAR-T.
Okay, so before CAR-T, I mean, what we try to do is to get the marrow done prior to the conditioning, or like after you are given inotuzumab also, you try to do a marrow and see in the aspirate whether you have achieved an M1 marrow. If you have not achieved an M1 marrow, we try to see whether we can give additional therapy. For example, the last patient we gave doxorubicin after, because the anode did not achieve because the blast percentage was 50-60% after inotuzumab. Because because what in literature or also center experience is that when you go ahead with a higher burden of disease, the outcomes are very bad, both in terms of the efficacy as well as, more importantly, the immediate toxicity is quite very high, because the CAR-T expansion is going to be very high with that much disease burden. So yeah, we do the marrow. Even if you have given inotuzumab, before you ultimately transfuse, we tell the lab that don't transport the CAR T yet. Let's get the marrow to, and we try as much as possible. We try to get the marrow to M1 before we infuse the CAR T. We have not found a significant VOD in the patients that we have given inotuzumab post CAR T, but our numbers are very less. But the literature I just reviewed and in the slides, and that also seemed to favor that. I mean, it's just an evolving one, but compared to transplant, it looks like it's much less.
Thank you.
Gopinathan.
Yeah. Morning, sir. Thank you for that revision. I would say a revision class on inotuzumab. It was clearly on the new updates also. So my first question is doing inonzo followed by TMLI. So in that case, do you take liver as organ at risk, or do we just consider it as organ to be irradiated? Because I can clearly see the radiation protocols, they do include all the skeletal system, thymus, spleen is to be irradiated. But liver is one area of confusion whether we need to consider it as a diseased organ or as organ at risk.
Yeah, so liver is generally yeah. So we had a patient recently. So we had an MDT with our TBI. I mean, the radiation oncologist. So we wanted to. I mean, obviously we are worried about the safety of the liver when additional radiation is incurred to it. So yeah, so I can't, I'm not an expert to give you the protocol on that, but then I'm sure we raise the same question, and that we don't want the liver to be stressed for this. So I mean, I know we are erring on the side of a relapse, but then I don't know. The experience with I know hasn't been that great when we were not adequately careful about it. I think all the mitigation strategies should be done when you have given INO, because it is a potentially very lethal thing. And if you lose patient, you lose the patient within 30-40 days. So
when we planned really it's a similar scenario. So when we planned dosing for this patient, they try to adjust if they're able to deliver marrow dose of 12 to 13.5 gray. Invariably, when they kind of excluded the liver becomes too much of a cold spot. It just gets only 2 gray or 3 gray. But invariably, most of our ALLs do have some hepatic involvement at baseline. So if we completely eliminate, keep it as OAR, the cold spots are too much. But if we include it, again, the gut toxicity, the gut and the renal toxicity becomes too much. So I had a confusion about this particular angle. But then most of the papers, even the TMLI paper from CMC said only if it is diseased, use it radiation, or otherwise keep it as OAR.
Yeah.
The second question that I had a doubt is, if at all we combine it to hybrid with INO CVD and INO mini CVD, so do you also do 1B methotrexate cytarabine after an INO mini CVD?
So I mean, if you, I mean, for some reason, the MD Anderson now doesn't give the INO with the CVD. Now it gives it with the methotrexate cytarabine. I think I can just reshare that protocol, if I may. Just yeah. So if you look at this, it is during the latest amended protocol that they follow with blinatumomab. This has gone away from where you give cyclophosphamide. So this INO is given only during the cytosine plus methotrexate arm. so So obviously, see, some of these things are not talked about. You know, even the first paper from MD Anderson did not talk about the anotuzumab, the VOD toxicity. They just put it in the supplement. Yeah. So, but when you probe and ask questions only, then you discover that, you know, the subtle things are happening. So they are not giving it during the hypersemia. They're giving it during the methotrexate and cytarabinam. I'm sure there's a reason for that. And mostly it must be the toxicity.
So your time point of marrow assessment when you do CBD, and it's a day 28, or what's your time point of marrow assessment?
Yeah, somewhere between that. So CBD less now. We mostly is So once you give the day 15 somewhere between, you know, day 15 to day 28, we do the marrow.
And between the transplant bridging, do you kind of do some 6-MP methotrexate kind of regimen, or you just leave the patient without any chemotherapy at that point of time, if you want to have a 6 weeks gap?
Yeah, I mean, some sort of a bridging we tried. I mean, some sort of an oral therapy we try to give, which is less toxic.
Maybe the last question is that many times the day 15 dose we aren't able to deliver when we see them in first relapse. By the time day 8, day 7, obviously most of our patients going for febrile neutropenia. And at that point of time, day 15 dose is compromised, or you kind of keep it for later. What is the strategy during?
Yeah, if it is compromised, we don't generally keep it for later. We do a marrow and see where we are after that, and then maybe decide on the second cycle.
Thank you, sir. Thank you so much.
Thank you.
Sir,
You're muted, sir.
You're muted, sir.
Sorry. So we have no raise hand sign, but we have a question from Dr. Akanksha. This is about lymphoma. So you've got a CD20 positive lymphoma, which is a relapse refractory. So your role about INO, you started your talk with that. So,
so very interesting that, you know, there's initial trial was done on lymphoma, and then it was a failure. The reason why it is a failure is probably because of the very unique mechanism of action of inotuzumab, because it goes and binds to the CD22 cells, and in the blood, it's quite easy for that molecule delivered into the blood to go into the blood or marrow and bind to this. But like with many other drugs, the solid kind of thing, like a lymphoma, and which is probably heterogeneous also, and the CD22 expression also might be heterogeneous, and there is a tumor microenvironment around that. It may be many reasons, but it has been a failure, and I have not seen much trials after that.
Thank you. So that's the last question. Any other question, please? If not, then we will let you go. Dr. Neeraj, thank you very much for spending your Sunday morning. You really updated us and also told us all about what happened in ASH this year. So thank you.
Thank you, sir. Thank you so much for this opportunity.
Thanks to our event management team. Thanks to the sponsors and everybody else. We meet on next Saturday. Bye-bye.